Dear Chairperson, thank you very much for the kind introduction, and I have to thank in particular Patrick Marcelin for involving me into this very interesting program. So my task is to discuss with you how do I treat my HDV patients. On this slide you can see my potential conflict of interest, which includes companies developing drugs against HBV and HDV. And I want to discuss with you one, let's say, typical patient. It's a 40-year-old woman born in Russia. She has been HBs antigen known for a long time, mild hepatitis, but HBV DNA was low. And then only after 10 years, somebody had the idea to check for Delta. She was positive, had an intermediate to high viral load. She underwent liver biopsy, and this showed liver cirrhosis. If liver biopsy is not possible or not conclusive for whatever reason, you may ask what's about non-invasive markers. And here the problem is that the standard markers do not work well in Delta, as shown by the group from the liver disease section of the NIH and also in our group from Hanover. There have been attempts to improve these non-invasive markers and to develop Delta-specific scores. So have a look at these papers if this is of interest to you. The first question to be answered for this woman is if we should treat HBV, the underlying HBV infection. And there is data from the HIV, HBV, HDV triple infected cohorts that received tenofovir as backbone of HIV treatment, where long-term efficacy of this NUC treatment could have been investigated. This is data from Switzerland. There's also data from Spain and from Asia. And you can see here that there's no effect on HBs antigen. Few patients in the long term may show an HDV RNA decline, but biochemical disease activity is not really affected. And my message is, in terms of HBV treatment, we should apply HBV guidelines. If there is liver cirrhosis and low replication, I would consider treatment. If there would have been no cirrhosis and only mild fibrosis, an HBV treatment may not be necessary immediately. Now, to answer the question whether this patient needs interferon, we have first to ask what is the risk of this patient for disease progression. And what we have learned from a variety of cohort studies is that Delta takes a severe course, but not in every patient. If liver viremia of HDV viremia would be low, then there might be even more benign course. But if liver cirrhosis is present, as in our patient, disease progression is really rapid. And you can see here that after 5 years, half of the patients had received in the Swedish cohort a liver-related event. So you may also apply other scores. The BEA-score includes markers of portal hypertension, including platelets. And if you would, based on her platelets and iron R levels, calculate the BEA-score, this woman would have BLB. And this, I think we all agree, cries for antiviral treatment. Before the approval of Bulevirtide, interferon was a treatment of choice. The data on interferon treatment has been discussed over the last 10 years. 1/4 to 1/3 of patients may show suppression of HDV RNA even beyond treatment, as investigated, for example, 24 weeks after the end of treatment. However, late relapses have been observed. Still, initially successful interferon treatment has been associated with an improved clinical outcome in many cohort studies from Italy, from Germany, from Turkey, from France, and also from Sweden and England. So I think it's quite clear if interferon is successful, the patient may have a benefit. This is the 10-year-old data from the HIDD-1 trial, and I'm reminding you on this data because we just recently published the 10-year follow-up of this trial. And why I'm showing you is this because some patients who have been negative at the end of treatment and early during treatment may experience a relapse even after 7 years after an initial response. So this really cries for long-term follow-up of every interferon-treated patients in Delta. Late relapses are possible. And only if patients remain HDV RNA undetectable, they really have a benign long-term course. Patients who are positive at the last visit still have a risk to develop clinical complications, even though the overall long-term outcome in the HIT1 trial was better than in other cohort studies that did not apply strict inclusion and exclusion criteria. Extending treatment with interferon to 2 years is also not very helpful. In the HIT2 trial, we still observed relapses even after a second year of treatment. However, this trial showed that low viremia, either at week 48 or 96 weeks of treatment, as determined here by a positive result in a more sensitive RoboGene assay. And if these patients had been negative with the in-house assay, but positive as RoboGene assay, these patients had a high risk of post-treatment relapse. So as in HCV, low viremia on treatment is associated with the risk for post-treatment relapse. So my messages apply the most sensitive assays in hand to really determine if your patient has a chance to achieve long-term benefit. If HDV RNA has limited role in really determining the long-term outcome, the question is, are there other biomarkers which may allow response-guided treatment? So, for example, stopping treatment after 24 weeks, if there's really no chance to achieve a post-treatment response. And we explored recently the role of HB core-related antigens. This is work by Lisa Sandman and Benjamin Masumi, which is currently in revision. And here we could show that this marker obviously correlates with HBV DNA, but not with HDV RNA. But if you measure correlated antigens on treatment, you can see here that the levels are much higher in non-responders than in responding patients. And on treatment, you may have a role to identify patients with a low likelihood of achieving a long-term response. So a marker that could be considered in the treatment of HDV infection to personalize treatment duration. In this case, our patient was treated with interferon. She had a response on treatment, but she experienced a late relapse after more than 60 weeks of follow-up. And now the question is really what to do with this patient. And obviously, she asked for Bulevirtide, which received marketing authorization last August. The package label states that the drug should be used in patients with chronic HDV infection, in adult patients with compensated liver disease, so no approval for decompensated cirrhosis, no approval for children, and the drug should only be used by a physician experienced in the treatment with HDV infection. The low dose Bulevirtide has been approved, so not the high dose yet, and only a combination with nucleoside or nucleotide analogs, but not with interferon alpha, is stated in that label. So to answer the question, how do I treat my HDV patients? I use HBV nucleoside and nucleotide analog in patients with advanced fibrosis or cirrhosis and detectable HBV replication. I still consider interferon in many patients, particularly without cirrhosis. But interferon is definitely no longer the backbone treatment of all therapies. Bulevirtide can be used in particular in patients with compensated cirrhosis and contraindications for interferon. However, in decompensated patients, at this stage, we only have NUCs to treat HBV, and we should explore, obviously, liver transplantation. The open questions are related mainly to the use of Bulevirtide in clinical practice now. What is the optimal dose? When to increase maybe from 2 milligram to 10 milligram? What is the treatment duration? When can I safely stop? What's about safety and efficacy in decompensated cirrhosis? What's about combination with pegylated interferon alpha? And in this respect, here I summarize in the table the data from the different phase 2 trials. We can really state that there's a dose-dependent effect on HDV RNA reduction when using Bulevirtide, 10 milligram better responses than 2 milligram. There is a synergistic effect when combining this with interferon on treatment, and there even the high dose has the most pronounced HDV RNA decline on treatment. But there were many post-treatment relapses, and interestingly, an reverse or inverse dose effect of bulevirtide when used in combination with interferon on HBs antigen reduction, which is obviously quite strange. And the current hypothesis is that the increase in bile acids, which is more pronounced in the high dose of bulevirtide, may play a role in this interesting observation. And finally, obviously, I think it's quite clear that novel strategies to achieve HBs antigen clearance, for example, as RNAs, need to be explored in hepatitis delta, and also here clinical trials are already ongoing. Would be happy to discuss some of these points, and thank you very much for your attention.